Now it's time for panel discussion. So I invite on stage all the keynote speakers, so Professor Metspalu, Dr. Geanta, that I don't see, and then of course Astrid, and then please Professor Martina Cornel, come to stage. She's the president of the European Society of Human Genetics. Then please Marius Kalliola also come on stage, program director in the Future of Wellbeing Solutions program of the Finnish Innovation Fund. Sit. Yeah. Now you sit here first, and then you will give your presentation. And a very important voice, patient advocate, Jillian Hastings. Welcome. And now I let Astrid to moderate this panel discussion.
Thank you so much, Angela. We'll wait. Okay, so first I want to thank all of you for being here and being available to talk to us and talk with us and engage in these discussions. So we've had presentations from Andres and Marius this morning, but I would invite the other members of the panel for a brief introduction of the themes and topics they would like to see discussed and where they think there's major challenges to be solved and major discussions that they can have with us. So maybe I would like to ask Martina first to come here. And I don't know if there's, yes, it's up again. Yeah, okay, there's it still.
Inviting me to be here. A little higher. So my perspective will be that from the Human Genetics Society, the European Society of Human Genetics, and I will speak about the contribution of medical genetics to personalized medicine. And as many of you may know, the first encounter that a newborn has with personalized medicine is when he or she is a few days old, and the neonatal screening is offered to all newborn infants in Europe, or most countries are offering this. It's a public health intervention, and it's trying to identify infants with treatable conditions where the effective therapy is more effective if you start very early onwards. If you start as soon as possible, the children can live healthier lives. And many of the conditions in the newborn screening programs around Europe are genetic conditions. PKU is, of course, the first one with which it started all more than 50 years ago, and the children get a diet and then they can just develop quite normal and go to regular schools and have normal jobs. But after that, depending on the country where you live, a few conditions have been added, or even something like 30 conditions have been added. It's not only genetic. Hypothyroidism, for instance, is a pretty frequent condition which is not genetic. So when we think about personalized medicine, we should not think about DNA only. But what is true today is that more and more conditions can be treated and screened. And many countries now have genomic newborn screening pilots. So investigations, research projects to see whether more conditions could be added to neonatal screening programs, hopefully treatable conditions where children can be recognized very soon after birth and start treatment soon after birth. And the second field where medical genetics can contribute is about cascade screening. There are many conditions, frequent conditions, cancer, cardiovascular diseases, where sometimes one gene plays a very important role in the etiology. And then identifying that condition in a person that has cancer or has already a cardiovascular disease is one step. But the next step is to, in a systematic way, invite brothers, sisters, and children, because while they are still healthy, there often are interventions possible. And yesterday evening we heard about familial hypercholesterolemia, of course, where the patients told us how important this is also for their community. On the right you see the 20-year follow-up of statins in children that were treated very early. And you see on the left that they have less cardiovascular events, while their parents had in 40% already cardiovascular events at the age of 40. The children, only one of them had a small cardiovascular event. And on the right, you see that lethality, the mortality is reduced very much. 40-year-old parents had already a 10% mortality before the treatments and before the screening. In the children identified, nobody died. So that's definitely very important to identify these people very early. But that cascade screening means that if you look at the picture on the top right, if there is one patient identified, you should investigate brothers, sisters, and children, and parents also, because they again have brothers and sisters. And if you offer in these index patients that test to their brothers, sisters, and children, you can identify also new people who also have this genetic condition. In the lower picture, you see the father and brother who then also have new first-degree relatives like brothers and sisters of the father or infants of the brother, who then also can get this test offer. And if you offer that DNA test to those people at 50% risk, they are the healthy people that can profit from preventive intervention. So that's definitely where preventive medicine can help quite a lot, and the effectivity is very high. I mentioned FH, familial hypercholesterolemia, but this is true for many conditions. Also, the scientific evidence is very strong for BRCA in breast cancer, but you could make that list somewhat longer because there's more genes involved. And Lynch syndrome in colon cancer. These three have been investigated quite a lot, and the evidence is very strong for these three. But of course, if you start such a program, you could add other cardiac conditions like cardiomyopathies or rhythm disturbances, long QT syndrome, and a few more. But thinking in this way and organizing a systematic program could help a lot in personalized medicine. And the other topic we talked about yesterday already, which is relevant from the genetic point of view, is of course pharmacogenetics, pharmacogenomics. Again, where there is scientific evidence available, we have to think about a coordinated program to implement what we know. In science, we have done quite a lot of work to identify genetic risk factors, but in implementation work, we still have to do a lot of work to reach everybody to profit. Yesterday, we heard about clopidogrel, which is a drug to avoid clotting, which can be given after cardiovascular events, but cardiac infarction, but also stroke. A small percentage of people do not respond to this drug, so if it's not effective, why would you give the drug? You'd better give a different drug. But that means that before starting this medication, you first have to do a CYP2C19 test. It's already in the information on the medication, but not everybody is doing this test before starting the treatment. Yesterday, Ron van Schaik mentioned that it took more than 10 years for the cardiologists to put it in the guidelines. Now we need everybody not just to read the guidelines, but also to apply it in practice. The same is true for the cancer field, where fluoropyrimidines are given a group of treatments in chemotherapy, which give very severe side effects for some people with DPYD subtypes. So a few % of the people may suffer very severe side effects, even leading to death sometimes. If you have already cancer, of course, you do not want to die of the side effects of the medication. So for these examples, there is very good scientific evidence. It is now in many guidelines, but the implementation is the challenge. So there we need to think about how we can study the implementation and decide on some key performance indicators. For instance, the number of deaths due to that fluoropyrimidine treatment, the number of recurrences of stroke after clopidogrel treatment. So the impacts need to be assessed, and if then indeed we see that just 70% of people get DPYD testing when needed, those other 30% need to be improved. If the lab cannot offer the test, send it to the lab next door, or if the doctor doesn't know yet, make alerts so that he will be reminded when it's useful. So my point here is that it needs to be organized. We don't need just to put it in our guidelines, we also need to organize alerts when you order it in your electronic health record, so that if you don't remind it as a medical doctor, your electronic health record will say, please look today at this specific variant in this specific patients, because you should not prescribe this drug, but either a different dosage or a different drug. and for medical doctors to understand that they need training, briefing, workshops, data collection. So we need to close that policy cycle, not only identify some new risk factors, but also think about how to really be sure that everybody is applying the knowledge that we have. So we need to monitor whether they are applying it, and if needed, adjust our policies. And that's what I wanted to tell you today.
Thank you so much, Martina. I would now invite Markus to give us his perspectives.
Thank you. Good morning, and thanks for having me. This is a very inspiring conference. My name is Markus Kalliola. I work for the Finnish Innovation Fund, Sitra. But first time I heard about these projects were perhaps when you started 10 years ago. I worked for the DC Sante, and we were setting up these personalized medicine things, and happy to see now after 10 years what all you have been able to accomplish, so congratulations on that. My topic today is a bit different than from the previous speakers, who are very scientific, based on risk scores and genetic topics. I speak about the regulation, so the European Health Data Space Regulation, and the joint action of 29 European countries called Data2 towards the European Health Data Space. So first about the regulation that entered into force this year. So the ESDS regulation is in force by 26th of March this year. I, of course, don't have time to go through the whole regulation, but three main things about it, in my opinion: Chapter 2, 3, and 4. So the Chapter 2 is the primary use of health data. So what access citizens have for their own data. The member states will need to provide seamless, easy, and costless access to the health data. And then it defines what called primary categories of health data: patient summaries, e-prescriptions, hospital discharge letters, lab results, and medical imaging data that will need to be able to exchange between the member states in Europe. So the data will travel from country to country based on the need of the patient. The Chapter 3 is quite important. For the first time ever, EU has put interoperability requirements for the electronic health record systems. They are mandatory, and you cannot base an EHS system in EU market after 29 if it's not compatible with the regulation. For wellness applications, it's not mandatory, but it's an option to be compliant. Today, of course, the main topic is the Chapter 4 and the secondaries of health data, where the joint action also performs. And there will be a lot of new things for the member states to implement, but not only the member states. The Chapter 4 defines data users, data holders, and health data access bodies. So data holders are basically anybody who have health data. The Chapter 4 defines what health data means, what health data is within the regulation, and it's basically everything that we collect, from EHR systems to surveys to national registries, death registries, disease registries, surveys, whatever. Medical device data is there, clinical trials data. So basically all the data that we collect in healthcare or research. It defines a new entity that each member state will need to set up, health data access body. It's the middleman between the data user and the data holder. The health data access body grants permissions to use the data, and then when the data has been granted, also collects them and places into secure processing environment. I will have one slide about the process. There's a lot of other things it defines, what purposes you can use the data for, what you cannot use the data for. Also some obligations for the data holders, for example, metadata requirements or requirements to implement what's called data quality and utility label, where they need to define how good data they have and how often they, for example, update it and that kind of things. All right, the timeline for the ESDS. As I said, it entered into force this year. In 2 years' time, we will have the final specifications for member states to implement. And in Data2, we are helping the European Commission and the member states to create those technical documents. This summer, in June, there was what's called the comitology process started in the European Council. So they are now negotiating on the final terms on the ESDS. The regulation is there; it will not change. But there's a lot of fine-tuning to be done before the member state then can start the implementation. The secondary use starts on 29 March, and then some other categories in 31. So the transition timelines are 4 years and 6 years, depending on the data. The Data Store Joint Action is a project of 29 European countries working together to create guidelines and technical specifications for all the actors on secondary use. So data users, data holders, and health data access bodies. Our aim is to have a harmonized implementation of the regulation. So to avoid some of the mess that GDPR caused when it was first implemented. Of course, the things has improved since, but we want it to be implemented right from the beginning. Where we are at the moment, so we have had already one round of public consultations for the work that we've done. First round was January this year, and the second round of public consultations that started October, and they will run until the end of this month. So there's still a couple of days' time to comment on our documents that is currently under public consultation. 11 documents altogether at the moment. The final round of public consultations will be May, June next year. So, what is the user journey for the secondary use of health data? How the data will be accessed and used in the future in Europe if ESDS framework is used? First, the data need to be discovered. Each data holder, so basically anybody who has health data, they need to provide metadata about the data that they have. And this metadata will be published in national catalogs. Then the European Commission will collect all the national catalogs together, and there will be one European Union catalog for all the health data available. The data users then can search the data from the catalog and submit a data application for the health data access bodies in each European countries. If granted the permission on the second phase, the data will be pulled from the data holders and placed into secure processing environment. Of course, the data need to be as well prepared. This means basically that it will be pseudonymized or anonymized, and also checked for persons who have opted out from the data use. The ESDS is opt-out principle, so there's no need for citizens to consent on the data use. The data will be used in secure processing environments. So these are defined in the regulation as a new concept, and each country will need to have those. The researchers can take remote connections to these environments. The data can never leave the environment, so the researcher cannot download the data, but they only access the data. Then they can take out the results of the study, but that will need to be anonymized and aggregated. And then finally it will be, the results can be published in the finalization phase. That's the easy path. Now, how the data tool helps on the process? There's different documents for each phase, so of course don't have time to go through these. The ones on yellow are the ones that are currently under public consultation. But there are documents to support each step of the way. So for example, we define what kind of metadata needs to be provided, what are the technical specifications for the catalogs, what are the technical specifications for the secure processing environment, how to do the pseudonymization and all that kind of things. There are some things that cannot be placed under the steps that I just presented, for example, fees and penalties for using the data, or how to opt out and things like that. Some are more generic. I want to present one of our documents that are currently under public consultation that might interest you. A lot of you are doing quite a significant research, and if you have a significant finding on the research, for example, about genetic things, there's one document that we just published that defines how the process goes for giving back the data for the citizens, so how to inform about the significant finding. And we defined these 4 steps for that. Some of them are outside the scope of the ESDS. So for example, we think at least that how to define a significant finding is in the competencies of the member state. But then the second step says that when there is a significant finding, that need to be provided to the HDAB, the health data access body. And then another article in the ESDS states that it needs to be transmitted back to the data holder where the data origin for the patient. Now then we go back to the national competencies, how to inform the citizen. So this is not defined in the regulation. If you have anything to comment on, for example, this document, you have still a couple of days time to do it on Tehda's website, and there's a QR code also for that. To summarize, Tehdas 2 is a project funded by the European Union and the member states, so it's a joint action of 29 countries. We focus on the secondary use and the implementation of the European Health Data Space Regulation. Our results are tangible, they are guidelines and technical specifications. So just to say that we are not building any IT systems, we don't have any data, we don't do any research. You can influence our work, so because you are the ones who enjoy or suffer the results. So thanks for this, and looking forward for the discussion.
Thank you so much, Markus. Very clear. And now I invite Jillian, as a patient advocate, to also talk to us a little bit about her perspective.
Thanks very much. Thank you very much, Astrid, for the invitation to come and speak today. It's nice to see a few familiar faces in the audience, but also to meet a new audience this week. My name is Jillian. I am the mother of a very rare boy, and we've been on our own journey through the personalised medicine world for about the last 10 years. So it's an honour to be able to come and be the concluding speaker in today's session and try and help bring us back to thinking about the role of families and patients and caregivers in all of this. And I'd like to reflect a bit also on my own professional experience as a patient advocate, which has come to be as a result of my involvement personally. Let's see if I can work the thing. Yes. So 10 years is a long time. We've been hearing a lot about this decade of discovery and development, from the wonderful reduction in the cost of whole genome sequencing, bringing us this explosion of diagnostic capabilities, and the consequential explosion in the volumes and value of bioinformatics data. But obviously that's now generated a huge demand for an equal explosion of treatments and solutions for people who are currently living with rare disorders, cancer, inherited other disorders, and basically a lot of other people who stand to benefit from personalised medicine. It's a privilege for me to be sharing this 10-year journey. I began as a parent. I became a patient voice, advising Genomics England in the work that they were doing to run the 100,000 Genomes project that we were participating in. And that has led on to my own opportunities to contribute to the development of the Genomic Medicine Service in England, helping to advise them on how they can bring in patient voices in a structural and systematic way to the work that they're doing, and make sure that the senior decision makers in those rooms are able to hear directly from people who are informed by lived experience. That has led on to the opportunity to recently produce an online course called The Power of Patient Advocacy in Genomics. If anybody has a few hours to spare, we are running this course with the Welcome Connecting Science team. It's available for free online through the Future Learn platform, and my contact details are at the end, so if you want a link to that, just let me know. I thought I had to talk for 5 minutes today, so there's a few things I haven't put in the slides, but yeah, just do get in touch afterwards. The other thing that I'm more recently involved with also is being part of a group of people who are setting up what's hopefully going to become a charity called the Global Genomics Network for Education and Training, GGNet, which is aiming to bring together educators, clinicians, researchers, and people working in this space across the world to try and push forward some of the educational piece that we've been hearing about from lots of our other speakers. This need to make sure that the professional audience are upskilled and ready to cope with the onslaught of demand for personalised medicine that's going to come. Anyway, on with some personal reflections of what brought me here. This is my boy. His name is Sam. He was born 11 and a half years ago, and when he arrived, we thought he was perfect. He ate well, he slept well. We could put him down for a nap when we had to look after his big sister. But after about 3 months, we realised he couldn't see anything. He had been diagnosed with a severe visual impairment. And between the first and second birthdays, he had 7 trips to the emergency room for increasingly, progressively complicated seizures. And that concluded in a diagnosis of epilepsy just before his second birthday. We had all the tests that were then available in the National Health Service in Britain. Nothing could find an answer for him, but we knew there was something clearly amiss. So we were offered the chance to join the 100,000 Genomes project in England, where we could be whole genome sequenced as a trio, his father, myself and my son. And that has proved transformative to our lives. We did get a diagnosis through the 100,000 Genomes project. Sam was the first person diagnosed in Britain with a GRIN1 genetic disorder, and I was astonished to find somebody in this audience who also knows what GRIN genes are, because it's super rare. The first time we had an opportunity to meet anyone else with the GRIN1 genetic disorder in Europe, there were 7 families across Europe got together in the Netherlands for a weekend, and that was in 2018. 2 years later, the week before COVID lockdown, we had 7 families from across the United Kingdom. Such was the upswing in diagnostic capabilities as a result of Sam's diagnosis and the inclusion of GRIN1 genes on the panels that they were using to look at patients coming through with undiagnosed profound learning disabilities, visual impairments, movement disorders, and seizure. So that's been a wonderful thing. And the ability to find community through that diagnosis has enabled me to be part of the team that set up the Cure GRIN Foundation, which is a global network of people who are interested in GRIN gene disorders, based in the United States, because that was the only place we had 2 people within one state to sign the checkbook in the days when such things were important. And they're doing great things. They got a grant from the Chan Zuckerberg Initiative for $450,000 US to start building a network of clinicians, researchers and families who were interested in coming together, identifying which are the most important features of our disorder, and then trying to catalyse more research into those things, which has been fantastic. More recently, now that we have enough diagnoses in Britain, there are enough people to get started on GRI UK as well. So that's a very new charity. We just started it last year officially, and that's looking to help people with GRIN, GRIA, GRIC and GRID gene disorders, which all affect the glutamate receptors, which is the G and the R. I am very conscious, however, that we're very lucky. We have a diagnosis, we have built our community, and we are in touch with researchers who know what our genes are and are interested in finding out more about how they work. At the moment, we're still hearing that about 25% of the participants coming through the genomic programs in Britain, at least, do get a genetic diagnosis. So 3/4 of the people who have a genetic disorder still don't know what it is. And that is a huge amount of unmet need. And there's a lot of people out there still waiting in the undiagnosed category. We're also conscious that at the moment there are still fewer researchers in the National Genomic Research Library looking at the data than there are diagnoses of rare conditions. So that's less than 1 researcher per condition. These things are going to have to change over the next 10 years, otherwise there's still going to be a lot of people still without a diagnosis. So that's a bit of an encouragement there to everyone working on that field to think about diving in even further. And once you do have a diagnosis, where does that really lead you? At the moment, we're still in a case where in many situations you have a genetic diagnosis and it gives you a label, and that label enables you to find your community, but it doesn't necessarily immediately follow that there will be a treatment, never mind a cure. So we're generating this ability to find community, and we are advised by the scientists that we should be contributing to natural history studies, to register our people in databases like you were mentioning there, so that we can be found more easily by people who are going to be able to do something with our data. In GRIN disorders, we're quite fortunate at the moment. There are a few companies who are interested in trying to identify some therapeutic targets for us. And in some cases, that has been leading on to some trial therapies. There is currently a study running, it's just entered a phase 3 clinical trial for a drug called Radiprodil, which has had very positive initial findings. In the phase 1 study of only a handful of GRIN patients around the world, they were able to observe an 86% reduction in and seizure frequency, which was just so exciting. So we're really hopeful that that's going to be something which can really make a difference to our wider community in due course. But it's still very much a journey of discovery there. And this leads me on to say a few words about the role of patients and patient advocates within this world. Sorry, this has got too many words on one slide, but I'm told I had to stick to 5 slides, so this is slide number 5. So thinking about the different roles that patients and patient advocates can have in this system, I'm a huge fan of making sure that decision makers get to hear directly from people who are affected by the conditions that they're trying to help. And the explosion that we've seen in the diagnostic capacity over the last few years has given us this explosion of small support groups as well. The proliferation of genetic diagnoses means that there are now thousands more labels than there used to be, and a lot more people putting flags out there on the internet and saying, is there anyone else in my gang? Please come and join me. So that's been a wonderful thing. But as I mentioned before, it's also generated a huge explosion in demand for therapies. And in order to be an effective patient advocate, you have to try and upskill, you have to try and learn as much as you can about the science. Even if you started without a science background, it's going to be important for you to learn a bit about how it works in order to contribute to the conversations about how it's going to be delivered. And it's amazing, parenthood does amazing things to your interest in particular subjects. I did no biology at school at all, and yet I've more or less kept up with what I've heard this week. So it's been a real journey of discovery for me personally for the last 10 years. But we can also then, with that knowledge, get involved in clinical trial design and implementation, start to help working with the drug developers to make sure that the endpoints that they're putting into their trials are something which is going to be meaningful and recordable for us. Some of the major assessment scales, for example, have steps between suggesting the development of a child's progression, which are too far apart. And even if we were to see modest improvements in our own child's ability, that doesn't take us beyond the threshold for statistical significance, which is unfortunate. So we're working to try and get more fine-grained measurement scales put into the studies that we're going to be part of. We can push for policy recognition, we can push for regulatory change. There's a lot going on in Britain at the moment, trying to simplify the regulatory landscape for very rare disease therapies. That's a very exciting world to be in at the moment, and I think there are similar initiatives elsewhere in the world. Not least what the Americans are doing at the moment, the announcement from the FDA recently about the plausible mechanism of implementing very rare disease therapies. But also we still have to live with the pressure of the expectation from the rest of our community. They hear that we're going to these scientific meetings, and what does it mean for them? They hear there's a drug trial and immediately assume they'll be able to get it from their local pharmacy. We have to try and upskill our community as we go to make sure that the expectations are realistic. We're all living in a world of resource scarcity. Trying to do things for nothing seems to be a common theme. And there is a risk of burnout. Obviously, 10 years of advocacy can take its toll if you're going to be reflecting on your own personal experience on a monthly basis. So we need to make sure that we're kind to our advocates and help them to live sustainably through that. The other things that patient advocates in my world have been able to do have been to talk about the contributions to the biobanking and the data initiatives. As you may know, Genomics England holds the National Genomic Research Library in the United Kingdom, and it has now got about 165,000 genomes, I think, in it. And they make sure that patient representatives and people who are actually in that data set have a seat at the table at the Access Committee to make sure that they're going to be feeding in what matters to them when they're assessing data applications. So there's that shared decision making, there's advisory roles on the use of data, there's the importance of communicating on behalf of an organisation holding this data with the wider public and trying to make sure that you can help get those messages to land where you want them to. And ideally, hopefully, as we move forward, there will be more opportunities to have advisory roles in the rollout of genomic medicine services too. So most of the things on this slide have a case study in my course, which is the power of patient advocacy in genomics, which I can tell you more about if you email me on that address. Thank you very much.
Thank you very much, Jillian. And so now I will open the discussion for the panel. I have a number of comments and questions, but I would like to see if there's questions from the audience already to the panel. Yes, so Wolfgang?
Sorry, just a curiosity. I really liked your last slide, and I'm just curious, do you have any communication channels to the private sector? Because we had yesterday the discussion that let's say ICPerMed, ICPerMed should further engage with patients and public, but also have communication with the private sector. So I was just curious, is there any communication from your side or the other way around from the private sector?
Thanks. The companies who are currently developing potential treatments are obviously keen to engage with us. But in many cases, you don't necessarily know about the small startups who are looking at these things until they make themselves known. So for us, it was transformative just creating a website that said, we are in the UK and we are interested in GRI disorders, because that yielded 3 different inquiries from 3 different researchers within the space of 3 months, just from being findable. So there's a little bit of that going on. But yeah, in terms of sort of structured, wider formulaic things, I'm not sure of anything that there is at the moment, no.
Okay, questions? Okay, so I have a question. Well, I have a number of... yes, oh, sorry.
Okay. Name is from Estonia. Thanks a lot for those very inspiring introductions. I have a question to Martina, Cornel, and Marius Geanta. You've spoken a lot about the implementation and those quality controls. So, what is your summary on how to get those trials with limited, interventions with limited evidence started and ongoing? Because other than this, it seems that we don't ever reach ready-to-use solutions in healthcare. Thank you.
Yeah, just a brief answer. There's not a simple solution. I think many countries are really trying to implement some of the knowledge that they have already, but the follow-up studies often need larger numbers if you follow the traditional paradigm of clinical trials, so their collaboration is key. And different trial designs might also be key. If you think about personalized medicine, perhaps we should move away from the randomized controlled trials with very large numbers and move to more N-of-1 trials, single-arm trials, comparison with historical evidence. And therefore, we need also that discussion with the regulatory authorities when they find something sufficient scientific evidence. If there is a genetic treatment for a very rare disease and the patient could not breathe on his own yesterday and can breathe on his own after the treatment, then the evidence from one patient, in my opinion, is already sufficient to move onwards. But that discussion is needed also with the regulators. Marius?
Yeah. From our experience, and I will start by saying that the European Code Against Cancer was launched 40 years ago, and the 5th edition was launched 1 month ago. And actually the awareness of the code is very, very low. It's less than 10% in EU member states. And this is not because the code is not good, because it's a lot of work, a lot of science, a lot of experts involved in this process for 2 years. The code is really great. But what is missing is to complement the top-down with bottom-up. And from our experience, what is really important, and I fully agree, when it comes to implementation, we should find different ways not to go to randomized clinical trials. I've seen some examples, using RCTs actually to assess the efficiency of some implementation frameworks. I think this simply doesn't make sense, absolutely. And from our experience, and we are now in the position, and as I explained, using social sciences actually to really coagulate kind of model, community-based, citizen-centric for cancer primary prevention. And now we are actually started to work with implementation scientists to actually mix the top-down and bottom-up and to generate a new implementation model. So from our perspective, I think it's crucial actually in these multi-transdisciplinary teams to include implementation scientists. And in particular, I think research action is really important, to do research, to implement, but always to be able to capture, you know, the impact, insights, data, and then to adapt the intervention.
Yes, Riley from Estonia. I have a question about the implementation of EHDS. I believe it's a question for all the panelists because, and first of all to Markus, because there are two data categories, medical images and genomic data, which is the most expensive to implement, and therefore the transition period is the longest for these data categories for the use of secondary use. It's 2031. But if for all the other data categories, there are central components, part of EHS, and these are financed by the Commission to create these standards and data catalogs, etc., then why genomics are not included in the platform provided from the Commission, or the discussions are not there yet that these should be included and financed centrally for the data discovery, for the catalog, etc. Because the genomic ethic is going to be established, but for the sustainability reasons for all the countries and equal engagement, it would be essential to include it to the EHDS platform. Has there been discussions in Texas 2 about these things, and could that be something what could solve the problem within 5 years for the secondary use of data? Thank you.
Yes, so for the genomics, as you said, the transition period is 6 years. For the secondary use, of course, for the primary use, we don't have the genomic data in the primary categories at all. For the secondary use, I didn't fully get what would be the problem of the metadata there. I think they need to be described as any other data sets using the metadata standard, the DGAT AP. How well it supports the genomic data, I don't have I'm not that deep into this metadata work, but I think it should support also the genomic data. So by 2031, we should have also the biobank data and the other genomic and genetic data in these metadata catalogs as the other data categories. That is my understanding of the topic. Now, whether there will be financing for what purposes, I have no news about the potential funding for ESDS beyond what we have at the moment. So of course there's a lot of Horizon money, there's a lot of EU4Health money available. The European Commission has given direct grants for member states to set up the health data access bodies, so there are some money already available, but I think of course the majority of the financing will need to come from the member states to create these ESDS services. So I think what we will have from the EU funds will be very limited. I think there's, for example, Denmark alone estimated a couple of years ago that the maximum amount would be 1 billion for Denmark. I haven't seen similar estimation from other countries, but I don't think that the European Commission or the EU funds can support the whole implementation of the ESDS. But it's the same for all regulation that the European Commission or the Union does. It's not that the EU funds cover all the implementation of the EU regulation in general.
I would just like to ask you a question, make a comment. So your first step is primary use, and there's an area of genomic data that could be very important to be in your records, which is pharmacogenomics. So because that when a doctor wants to prescribe something, maybe they should have that warning that Martina just mentioned in the healthcare, in the electronic health record, saying, well, this patient cannot take this because it has this variant. So that is something that is so close to healthcare, and that we really need to force implementation, but could be already within the European, the EHDS primary use.
Yes, so also not being when I worked for the Commission, the primary was my work. So I started the My Health at EU infrastructures and setting up the exchange of patient summaries and e-prescriptions. I think at that time we had some discussions regarding what sort of rare disease codes can be used in a patient summary. I don't know the current situation. There's another joint action called XDEHR, where they actually discuss about all these primary category data. There's no specific for genomics, but I don't know what exactly they have in a patient summary, because there's all the basically your prescriptions and your allergies, your diagnosis and those. So how far it goes into defining these rare symptoms or your genetic data. Maybe some of here, maybe in the audience knows better about what is the exact contents of this patient summary, but that theoretically at least could support that kind of a need.
So is there a mechanism for suggesting this to DHES?
Yes, definitely you can discuss with the XDEHR project, which is another joint action of the European funded by the EU for Health program. And they are currently defining the technical standards for patient summaries, e-prescription, lab results, medical imaging, and hospital discharge letters. And they are finishing before the mid of next year, so I think they are finalizing of their work. But both for the TEHDAS 2 work and the XDHR work, this is kind of like the groundwork. And the final decisions will be made in the comitology that is done in the Council between the Member State and the European Commission. So any here who are in contact with your national decision makers, you can also raise these to your Ministry of Health, because they have the national delegates then discussing in the Council about this topic. So that is then the final place to make changes. But of course it's easier if it comes through the XDHR, because then it's the opinion of all the Member States, and it goes probably through easier than if it's just few Member States raising hand on the Council.
I don't know if anyone else wants to comment on this. Martina, yes?
Yes, when you think about genomic data that are today stored in healthcare records, I think we have to realize that often they are not reusable in a very simple way, because they may have been stored in a certain way for 2 years, and then the next year they were stored in a little bit different way, even in the same center. So making them fair, especially the reusable, also requires them to be in a certain standard, and it might take quite some work to get the healthcare genomes out into a reusable format. We have to think also about genomic data as just data, not yet results. So at the moment you want to look at genomic results of a person or genomic data of a person and to change that into a CYP the 2D6 phenotype, it takes some work to really look at the data, move from there to star alleles, as we talked about yesterday, and the combination of the star alleles, because that combination of two often decides whether you are a fast metabolizer or a slow metabolizer, etc. So that's not something that is already in the data, but it needs some work at least to get the phenotypes out. So first we need to have the data in a reusable way, and then we have to think about the analysis. Of course, if one center like Estonia does it, perhaps it can be used also in many other countries. So I look forward to your suggestions to reuse that kind of solutions in our data in our countries.
Just a quick comment. That's what I meant. We don't need to reinvent the wheel in 27 times. We can use it centrally and put it as a building block for the EHS. So.
Sure, we don't need to reinvent the wheel, but we may have to do some additional work in each country, even in each hospital, even in each year in which the data have been stored.
Indeed.
But the additional work might be limited as compared to the larger investment.
I agree.
Emanuele Oldoni from Iatris. Thank you very much for your beautiful presentation. I want just to mention as general information that we are working with the Precise EU project, and we did a large analysis of different regions and country readiness to the EHDS. That is, the data are publicly available in the website. So, and I think that indeed the most important aspect that we highlighted was the lack of infrastructures. So we have really to work a lot on the building actually infrastructure, especially how it has been said by Marius, also in the more countryside region where actually hospital cannot really have good, let's say, infrastructure in place to also record healthcare data. And on this side, I would like to hear from you also, what do you think about the trust of citizens on sharing data? Because I'm Italian by origin, so I have a cultural, let's say, bias there, but then I moved to the Netherlands, where I'm experiencing some differences there, like where people trust more as far as the institution are transparent, they are very keen to share their data. So I was wondering on your, from you, what do you think about this, how we can build this trust, and also from a patient perspective, how easy it is from someone that is just like in these jumps in this situation where you have also emotional aspects involved to actually trust the healthcare system, trust the people you are working with in order to actually give a better life to your child. So I know it's a lot, but it's nice to hear a bit your impressions on this. Thank you.
Thank you for the question. Yeah, trust is absolutely essential. And I think the way that we were able to be part of the decisions about who was going to access that data was unusual but great. So as a patient, you know, or a parent of somebody who's got a rare disorder, if you don't know what's wrong with them, you're going to be more inclined to want to share your data. You'll be more willing to share because you'd think that that's going to get you towards an answer. And it's not the same for the healthy volunteers in the biobanks. I know they do it differently. But I think in some ways, perhaps your appetite for risk is a little bit bigger if you're worried about someone that you love and you don't have an answer for their health problems. So you're perhaps more willing, maybe too willing, to share with an organisation. But having decision-making structures where the voices of people who are living with these disorders or who are representing members of the public as part of the access committees, for example, I think that can really demonstrate from an organisational perspective that the organisation is listening to people, citizens whose data it's looking after. So I think, yeah, having that level of interaction and responsibility is really good and important.
If I can follow up on that, there was an example where the European Society of Human Genetics recently was involved in a plan for a big newborn screening project in Greece, a genomic newborn screening project. So after a pilot, they intended to, in a few years' time, screen all newborns with genomic techniques. But the data from that study, if you would want to call it study, would go outside of the country to an American company. And the plan had already been developed pretty far without consulting all the relevant stakeholders, such as parents' organizations and such as the traditional newborn screening people in the public health sector. So the European Society at that point in time said, maybe this is going a bit too fast, and please, first of all, speak to all the stakeholders. Many people will still feel that genetic data is more sensitive than other data. So giving for all the newborns, all the genomic data to a company, not in your country, might simply not be a good idea. So to keep the trust, we really need to speak with all relevant stakeholders early in the process, definitely also with the parents and people involved in those children.
I can also add that in Estonia, in biobank, 25 years, we had not a single incident. But in the framework of Gene of Europe, we conducted a poll now in 5 countries: Estonia, Portugal, France, Slovenia, and Greece. And we just received the data, and we are analyzing them. So pretty soon we will make it public. So how these countries actually people? We are asking 1,000 people from each country, and some of these questions are related to the public trust, how would they like to share data and so on and so forth. So I guess we get a kind of fresh view, and what we have to do in 3 years later, we have to do the same thing, and we have to see is there any progression or movement for the better.
Maybe to complement what has been said, I think that the trust is the key ingredient when it comes to genomics, to European health data space, AI. And we actually, when we started to work with social scientists was in pandemic, right? Because we've seen in Portugal, vaccination rate against COVID, 90%. Romania, 42%. Bulgaria, 38%. And we said, you know, it's the same vaccine. Is not an issue, you know, the access, because was, you know, it was the European Commission who actually buy this and distributed the same day to all the countries. So what actually made the difference? And we started to work with social scientists, and they said, you know, it's an issue of trust. And then we entered into details, and was the trust in government, in authorities, and so on. And then we move forward, and we've seen actually the same issue when it comes to HPV vaccination and other topics of interest. So the main point here is, you know, how actually the European health data space will be implemented in a certain member state where the trust in public authorities is very low. Because this should be done by parliaments and governments. And how will you increase the trust, you know, of the general population in something that is coming from, you know, from the government and from the parliament? It's not easy. But it's a totally different story if you go at the local and regional level. Just to give you one example, we had elections last year for the mayors, and usually in this kind of village, a mayor has like 90%. So people really trust the mayor, you know, and they vote 90%. And probably a smart way would be actually to find ways to really engage with the local authorities on this type of topics. You know, sounds extravagant, but I think for the people it's highly relevant. And in my opinion, and this is my last sentence on this, so I think the European health data space would create a lot of opportunities for countries that are not famous for using data or having registries in place. Okay, because, you know, on one side, you'll have this regulation and you have standardized patient summaries and electronic health records, and who will be populated with data. And then, and this will open, I think, a new way actually of start discussing with the citizens and with different communities how actually to come together to consent to put data together and to contribute to different research projects and so on. So I think this is slightly a different model of governance, and we should explore in order to really make an equitable implementation of the European health data space.
Can I very quickly, I think when you're thinking about trust and being trustworthy as an organisation, I think it's really helpful if a data custodian can explain what will happen to the data that they're holding, but also what will not. So to your point, we will not share this actual data, we will make people come and look in our research environment, or we will not sell it to pharma, or we will not speak to insurers, we will not share your sensitive health data with particular categories of agent. And so creating that sort of red line is definitely a way of building trustworthiness.
Just a short comment. Sharing, this is really bad word. But the thing is, so we have to, 2 points. You're building a trust for 25 years, and in one morning they can actually trust completely. The newspaper is coming up with a story, you know, being a gene donor will kill you. And, you know, it's done. But what we have to do is, as a community, as a scientist or doctors, we have to talk more. Because I'm listening kind of radio broadcast, and, you know, somebody's talking against vaccines, against statins, against something, and not a single doctor is calling in and saying that, look, this is all, you know, wrong. Absolutely no, because people don't want to get involved in these things, but we should. Otherwise, you know, the other side will win, because there's only few people can make up lots of noise in social media. So we have to act, actually.
I fully agree with the previous speakers. In TEHDAS 1, there was a joint action before the current project. We did a survey in 3 member states, France, Belgium, and UK. We surveyed around 3,000 individuals, and one of the main findings from that survey was that the more people knew about the secondary use, the more in favor they were, and the less they knew, the more afraid they were. And I think it's exactly as Andres was saying, that we need to talk more and we need to educate people, but of course it's very difficult to educate somebody who don't want to be educated, and they want to look to the social media and watch soap operas and whatever. So the public authority and the health institutes media exposure is basically their website and their social media channels, and nobody's following. So it's a very difficult thing, but of course, as Andres was saying, you can lose the trust in one thing. So what we need to do is, of course, make sure that everything is safe as it can be, and the pseudonymization works and the safe environment works, so there's no like cybersecurity issues and so forth. But it's a huge issue, this public trust. And I'm really the wrong person to talk about it, because Finland is one of the countries with the highest trust for the authorities. So you kind of like take everything for granted, and it's we should be more skeptical about things in my society, I think. One example, and I finish then. We moved from paper prescriptions to e-prescriptions years ago, and now we have a law that the paper prescriptions are not allowed and all that. And then there was a French official coming to Finland and asking, like, so how did you make the transfer between paper to e-prescriptions? Like, we are trying that in France, and it's hard to get people to consent on the e-prescriptions. And they were like, my brain froze for a moment. I'm like, there was no consent, there was nothing. It was just like a decision made, and nobody complained. And people are interested in getting the drugs from the pharmacy, not how the information goes to the pharmacy about the drug, whether they're delivering it themselves or whether it goes through some other means. So the society works different ways in different ways of Europe, and I think we need to all work hard to get citizens on board.
Two things, very short. We have to publish more positive stories, because media wants to have trouble. They publish always bad stories. But if somebody is getting help because of personalized medicine, because of genome sequencing or whatever, we should really talk about it. So this actually helps other people to, if they are not sure what to do. And the other thing, what I think, younger people are living completely different media space. And all of us, we don't know exactly how to approach this, because they don't read papers, they don't watch TV, and they just communicate in a different way. So we have to approach these ones also, because after 10, 15 years, these are the opinion leaders.
Just to add, it's not my intention to make things even more complicated, but but I have to say, and this is coming from an analysis done by a group working in our project and dealing with fake news and disinformation and misinformation. And what they identified, actually looking to different Facebook groups, was the following pattern. So for years, where groups, where people express against vaccines, natural products, all these narratives for years. So people invest, and these groups become bigger, bigger, and bigger. And what happens in 24, a super electoral year in Romania, 5 rounds of elections, many of these groups actually change from health-related issues to political issues. And the idea was, because this is something, and they have evidences, who actually promote this kind of group and what was the interest, of course, against the EU and so on. But they act using something that is very personal, the health of the interest of the people for health, and then they switch this to political reasons and so on. And my message is, this is something that cannot be tackled by us. part of the health system or researchers. Of course, I fully agree. I go every week, to national broadcasting station to discuss about health innovation, but it's not enough. And this because we are in an European partnership for personalized medicine event. I think it's really important actually to connect with the other DGs and European institutions dealing with hybrid wars, and I'm not familiar with this, but I think it's really important actually to connect and to consider this dimension.
Just to add a little bit, yesterday we had a podcast interviewer, and the first person speaking was a very young person, I think younger than 30. As European Society of Human Genetics, we also realized that my generation is not a generation to be on the social media. So we have ESHG Young, and they are the ones that prepare the messages for social media. So perhaps we also need an ICPerMed Young and an ICPerMed Young.
I agree, exactly. I think that's a very important point. First, spread the good news, and Andres, that's very right. Spread the positive word by the younger people, and maybe using, like WHO, influencers across Europe and elsewhere, because that's something maybe we can think about, see who are the influencers that actually young people follow, and try to get them to spread this kind of positive messages and interesting ideas related to personalized medicine. Still thinking that personalized medicine is mostly used for older people, and that is something that, maybe we're not doing enough at the pediatric age, and we've had that comment as well today and yesterday, I think. So, right.
Yes, just a comment from me. I agree that different age groups in different countries must be addressed differently by different media, by different means. I remember when Andres started the Estonian Biobank, how the samples were collected, the story was taken to soap opera or TV shows for different age groups, and it was communicated easily. How the children should explain their parents why is it important, how a neighbor explains to neighbor what is the benefit, and people got engaged because they got the value offer, and they get a real results back to through the donors portal. And what Markus said, in Estonia we have no problem with the public trust because of transparency. We are transparent about solutions, and we do a lot of explanations. But what we would need in ICPerMed and ICPerMed is most probably translated in all languages, snapshot clips, TikTok clips, but how do you explain genomics in 3 minutes? We must take it into the pieces to put the puzzle together for young people. And I think it's important to engage the programs also at schools about to educate also the children. Personalized medicine is not only for elderly people, because newborn sequencing gives a lifetime possibility for a person. It is a value to be offered. Yeah.
Thank you, Riley. More comments? We still have a little bit of time for discussion. So
maybe still commenting on we need clips of just 3 minutes. Maybe then we don't need to explain genomics 100%, but just take the few examples, or just one example for 3 minutes, and put several of those small examples on social channels, like a person that profited from one DNA test or a person that profited from another DNA result, one parent couple of a very young child, one person of 60 plus or older who got a certain chemotherapy which was different from the one that many people get because they had a different genotype. So we need short stories of small examples, not of genomics as a whole.
How can we work with the European Society of Human Genetics in this context? Is it something that could be foreseen?
Already we are preparing webinars, so we moved away from having just one conference a year to having every month something ongoing. But I think we also need to collaborate with the patients because they have the strongest stories. So I definitely think you could make an outreach to the European Society to find some examples. But I think we should look to also the patients that tell why this was good for them. And for that we don't need just the researchers and the doctors, but also the patients.
Absolutely. So here, maybe I would like to raise the other issue that has been discussed a lot, which is equity. And how can we make personalized medicine more equitable? How can we, is this a, I think Marius presented a bottom-up approach, really, very much getting to the communities and going from there. But do we also need a top-down approach so that norms are established and made, more compulsive, let's say, for testing, for instance, DPYD? We've had thought about that. So, what is your opinion also on this, and how can we make sure that I don't know if we can make it sure, but how can we progress towards more equity in terms of making personalized medicine more accessible in the European context and in the wider context?
Yeah, I think there's two aspects that I would like to stress. One aspect is that we know many of the variants of people of Western European ancestry. So within Europe, we have, of course, many people who are living there who don't have Western European ancestors or who have partly ancestors from other parts of the world. And we really need to make an effort to also have the information on their variants. In the United States, they had for several years an initiative where there were only funds from the national government given if you had at least 10% migrants in your studies, or people of ancestry other than the usual Western European. Maybe as a European Union, we also need to think about stimulating or even forcing studies to incorporate people with different genetic backgrounds, different ancestries. So that's part of the solution. We need to understand the variance in people with our ancestries. The other element is who gets the test offered. And now that very often depends on me asking for a test or my doctor being informed about what is possible. And we should more build that in our structures so that once somebody is thinking to prescribe me a certain medication for which a pharmacogenetic test would be very useful, it should not depend on me asking or the doctor offering. It should depend on the system showing that alert. So building that in as a routine is what we need. I think you also performed some studies showing DPYD testing was done in 70%, I think in Italy, so 30% didn't get it. Well, it should be automatically. I don't get this group of medication if I haven't a test result showing that I can have that medication. It should be kind of systematically built in our systems. That would lead to equity.
And part of it comes back to trust and to education again. People have to trust that they're not going to come to harm by sharing any information or having a procedure, but also knowing about what's going to happen when it does happen and why it might be helpful to them is something which not everyone will understand. So across the different communities that we have living in Europe, more outreach to those who maybe have been more traditionally skeptical about this would be a good thing.
I've been thinking about it also because on population-based approach we need most of them engaged. And primary care providers actually have everybody's address. And but even in Estonia we have probably a few percent, I don't know whether it was 3% who have, they don't have a primary care provider. So they are not in the list. So these are difficult to catch. But basically if there is a governmental program, so you just primary care got funded, send a saliva kit and we text that, look, you just come, we just check your risks. And when one group offered low dose MRI for screening lung cancer on smokers, they got, like I would say, 70-80% came. If you just publish a story that, okay, please come and do the whatever test we offer or participate in the project, and you don't tell why, then 40 or 50% is coming. So ethicists don't allow, at least up to now, didn't allow us to send a letter, look, you have very high risk of cancer, please come to the check. We have to tell, look, please come, we just check. But people engaged so many projects, at the end of the day said, okay, you know, nothing happened, I am not going. So we have to actually tell them why we need them, and these people then is coming. We can't play these games that we don't know anything. We know, and we do know, and we have to engage them in order to improve things. And I know I'm not very popular with this statement, but we have to think about the future. If we want to improve the things, we have to get at least 80% of population in this PRS-based test. This is my...
If you got a letter that said, you have a high risk of cancer, please come and see us for a test, how long would you want to wait between receiving the letter and going for the test?
If I get this letter at the time I risk, I just go immediately and say, just put me into the list and make sure that I am not going to miss this cancer. When it comes, I'm that. You know, let's say in breast cancer, you know, women just don't test them every day. But if you are on the list, you just do it in your bathroom every morning. So I guess it's to know, it's better than not to know. But of course, I know there are people who don't want to know. Okay, let them be. And you know, you can jump from the bridge also, please. But most people want to know.
Well, I think it's really important to your point, to really stratify the target the population according to their preferences, their interests, and many other details that should be, and I think this is the key for equity, should be captured from the very, very beginning using, you know, ethnographic analysis, including the cultural factors in this design, and then, and it's not easy, it's really complex, because as I mentioned in my presentation, some of the people, they are really interested from a result coming from an AI, but if this result is endorsed and offered by a medical professional. So we might have a group of population who might be interested, you know, the family doctor to say this, others might, you know, simply receive a letter. So the point is, I think it's really important in the design of different tools and interventions actually to put these social factors and cultural factors from the beginning, and we cannot do it without proper expertise, meaning social sciences and humanities.
I agree absolutely, because early times I didn't really regard social science as science, honestly, like 25 years ago. But now I'm actually changed my mind. And
that's always good.
But look, we have to do the health audit. I would call it health audit on the population. And if we do health audit, then we know what to do and whom to do. But can you imagine, you just go to MRI, and 100 people will go and say, discover one lung cancer. So you just get radiated. This is harmful to your health. As people still go because they get instrumental diagnostic procedure, whatever. They are not looking your kidney or your whatever else. They just look your lung cancer. But I told them, look, invite these people who have a high risk of lung cancer, and do the MRI, then you discover more than 1 per 100.
Maybe still I have to talk about the other side of the coin. Breast cancer screening has been mentioned a few times, and PRS as a possibility to improve the efficiency of that screening, but the treatment of breast cancer is also improving so much that the benefit-harm ratio is changing a lot over European countries, and that many people feel like maybe we should not increase the breast cancer screening that much for younger women, because the harms in those women are getting more and more larger and larger. So when you speak about adding PRS, I think please do a study showing that for the women that have the highest 1% risk or whatever, it is really adding to their benefits and not adding to the harms in those populations.
Study was published last month, you know, on Nature Review Genetics. Breast cancer together with us, it's really helpful. It's 13 diseases. But look, I was showing the slides that 20% of this breast cancer happens younger people, and these are excluded.
But even the younger people have much better treatment results today than they had 10 years ago.
But younger people have more aggressive cancer.
Still, they survive more often now than 10 years ago.
Okay, well, you can go on over lunch. I'm very sorry, but I think we need to stop. And I was going to ask all of you to, in one sentence, say how you think it would be great to, how you can contribute and how ICPerMed and ICPerMed can actually contribute to your perspectives, respective perspectives, and and then we wrap up that way. So, Jillian, I know you have a little message. 1 minute, not even 1 minute, one sentence.
Yeah, I have 3 bullet points. 1, keep inviting patient voices into your conversations. 2, recognise the value of patients as idea generators and road testers, as well as bringers of personal stories. 3, help to educate the patient advocates and the patient communities. Things like you, Patty, that we heard about yesterday are excellent. So thank you for all your support, and let's keep working together.
Yes, thank you so much, Jillian.
No, I don't see any harm of giving a saliva kit and get a PRS, and a primary care provider explains you what it means, and you have a road map. I would say call today is a patient path, patient road
Journey.
Patient journey, and you went. So this is your patient journey will be determined, and you never miss. And it's right time to start treatment.
Thank you so much, Andres.
For me, ICPerMed and plus ICPerMed is such a great learning environment. So many ideas and inspiration, as always, and thank you very much for that.
Thank you so much, Marius, for all your contributions today. And congratulations for the award.
I would stress collecting scientific evidence of the specific applications of personalized medicine, which then, after the scientific evidence is clear, need implementation, not for just a few, but for everybody.
Thank you so much, Martina, also for your perspective.
Yes, so from my side, I think there's so much knowledge within these both communities, so I would urge you to take an action and comment the data2 work, also probably the XTHR work on building the European health data space so that we could make it as good as it can be.
Thank you so much, Markus. Yes, excellent perspective as well. And now I think we're done, and you are wrapping up the...
Well,